I'm Sheila Fite, U.S. Clinical Lead in the BMJ Evidence Center, and I welcome you to our webinar about type 2 diabetes in adults. Today we will be looking at type 2 diabetes in practice based on our BMJ best practice topic. This webinar will concentrate on diagnosis and treatment issues. Our speakers today are Drs. Patrick O'Connor and Joanne Sperl-Hillen, co-directors of the Health Partners Institute for Education and Research, Center for Chronic Care Innovation in Minnesota. Both clinicians are actively involved in research about chronic disease, diabetes care, and cardiovascular risk reduction, as well as the use of electronic tools to facilitate provider and patient education and engagement. They have also served on working groups such as the Institute for Clinical Systems Improvement Diabetes Guidelines. Drs. O'Connor and Sperl-Hillen are the authors of our Best Practice Type 2 Diabetes topic and regularly updated by evaluating and applying the most recent and relevant evidence and international guidelines. Also with us today are several BMJ staff, including Clark Greenhuber, Product Manager for Clinical Decision Support, and Michael Sussums, our Head of Training. Today we'll be spending about half an hour reviewing the topic, allowing time for discussion afterwards. During the presentation, please do post any of your comments or questions into the chat box, and we will make sure to try to address these after the presentation. Now, Drs. O'Connor and Sperl-Hillen will lead our presentation.
Hi, this is Joanne Sperl-Hillen. Can you hear me okay? Today we're going to do a complete overview of type 2 diabetes using the BMJ Best Practice website, which you should be able to see from your screens. We're going to talk about the current management guidelines and discuss also new evidence and topics that are currently under review and may change guidelines in the near future. We're going to be discussing the highlights about diabetes, some basics, some information about prevention, diagnosis, treatment, follow-up, and also we'll introduce you to some other valuable resources that you may like to use in your practice. So the management of type 2 diabetes focuses on glycemic management, but also on blood pressure and lipid management as the major focuses. It's important that we remember to individualize targets for people with diabetes. A one-size-fits-all approach doesn't work, and so we'll be talking today also about things to think about so that you can individualize treatment and personalize it for your patients. So with diabetes, this is the opening of the BMJ, the summary of it that emphasizes the blood pressure and lipid management, in addition to glycemic control, individualizing therapy, and you'll notice a number of other links to related conditions. And what I had done was just clicked on the depression guideline, which is also very important for people with type 2 diabetes. Type 2 diabetes accounts for about 90% of all diabetes. It's estimated that the lifetime risk for developing diabetes is around 40% and maybe even higher in non-Caucasian populations. Type 2 diabetes is usually preceded by many years of insulin resistance and hyperinsulinemia and the condition called prediabetes. It's also associated, diabetes is also associated with very high concordant rates of obesity, lipid disorders, and hypertension. We know that type 2 diabetes is preventable, and the screening guidelines for type 2 diabetes have been somewhat controversial recently. The ADA has recommended routine screening of non-pregnant asymptomatic individuals for adults with a BMI greater than or equal to 25, plus one or more risk factors for diabetes. The screening has become a little less controversial with the very recent U.S. Preventive Service Task Force changes that are much more in concordance with the screening recommendations of the American Diabetes Association. The U.S. Preventive Service Task Force is now recommending universal screening for individuals in the age range of 40 to 70 with a BMI greater than or equal to 25. So diabetes screening now is becoming much more universally accepted. The diagnostic criteria or the way that we screen for diabetes is one of 3 tests. You can either use an A1C test, a fasting plasma glucose, or a 2-hour post-load glucose after a 75-gram oral glucose, so the OGTT with a 75-gram oral glucose load. Those are the 3 acceptable ways of screening. The A1C is probably is the simplest way of screening because it doesn't require fasting and is much easier. Diabetes can also be diagnosed with a random plasma glucose that's greater than or equal to 11.1 millimoles per liter in a patient who is symptomatic. In the absence of patient symptoms, it's recommended that one of these screening tests, and preferably the same one that was done to begin with, is repeated on a separate occasion. So there are many risk factors for diabetes, and let's go. These risk factors are older age, overweight, obesity, gestational diabetes, a history of prediabetes, a family history of type 2 diabetes, a Black, Hispanic, or Native American ancestry, sedentariness, PCO or polycystic ovary disease, and anybody with hypertension, dyslipidemia, or pre-existing cardiovascular disease are at extremely high risk for developing diabetes. Most patients with diabetes present asymptomatically and are picked up through screening. But if the glucose is high enough, then there are also common symptoms that can develop, including fatigue, blurred vision, paresthesias, polydipsia, polyphagia, polyuria, and acanthosis nigricans is also a rash that you may notice that is more prevalent in people with diabetes. It's this velvety brown-looking rash that often develops on the neck and under the arms and in the groin area. So I'm going to turn this now over to Patrick, who's going to discuss some of the treatment details around type 2 diabetes.
Okay, thank you, Joanne. That was a great introduction. I think that when we consider the treatment goals for a person, an adult with type 2 diabetes in particular, it's important to think about what the potential benefits of the treatment are to the patient. Now, we all are familiar with the concept of microvascular complications of diabetes, the eye, the foot, the kidney, and others, and those are remediable or preventable, I should say preventable or delayable by aggressive glucose control, and in some cases also by good blood pressure control. So over the years, and due to the pathophysiology of the diabetes being so closely linked to glucose disorders of glucose metabolism, there's understandably been a strong focus on glucose control as a principal treatment priority in people with diabetes, and that's certainly true. However, if you look at the epidemiology of patients that have type 2 diabetes, by far and away the leading cause of death is heart attacks and strokes. In fact, a detailed study, cohort study of all the people with diabetes in Denmark over an extended length of time of roughly 15 years, published in Diabetologia by Hansen a few years ago, showed that there were 47 among people with diabetes. There's 47 deaths from heart attack, stroke, or direct cardiovascular complications of diabetes for every 1 death related to microvascular complications, principally renal. So the ratio of 47 to 1 macrovascular to microvascular deaths. On the other hand, microvascular complications, blindness, amputation, the need for dialysis or renal transplantation are things that patients are very, very concerned about, and physicians are too. So the net impact of our understanding of the disease at this point in time is that it's important to deal with glucose control, but it's also important to deal with blood pressure, lipids, smoking, and to consider antiplatelet therapy and weight management as important clinical priorities as well. So we're going to address blood pressure control here. And on the screen, you can see some text related to blood pressure control in people with type 2 diabetes. The general blood pressure treatment goal currently in the United States is less than 140 over 90 millimeters of mercury. And this is somewhat controversial. I think that in the ACCORD trial, there was some benefit to treatments less systolic control less than 120 with respect to stroke, but there was no benefit with respect to the pre-specified composite outcome in that study. So as it stands now in the U.S., the blood pressure goal is less than 140 over 90 for people with diabetes in general, but it may be that people with a very high risk of stroke, the treatment goal may need to be individualized. In addition, a paper that's going to be published in a couple of weeks called Sprint, that'll be presented at the American Heart Association this month, apparently suggests that a goal less than 120 is a benefit to some patient groups. So we haven't seen the last of the debate on blood pressure control. But at any rate, whether the goal is less than 140 over 90 or whether subsequent research reveals that a lower goal would be beneficial for some patient subgroups, we know that people with diabetes are often going to require multiple blood pressure lowering medications to reach their goal, often 2 or 3 medications. I think the average is about 2. So that as a clinician, you should be on the lookout for hypertension, which affects 70 to 80% of people with type 2 diabetes. Treated aggressively and early, there's evidence that treatment within the first 3 years of elevated blood pressure has a measurable impact. Treatment within the first 6 months of elevated blood pressure has a measurable impact on the occurrence of strokes and heart attacks within a period as brief as 3 years. So prompt identification and treatment of hypertension using recommended drugs, which currently include diuretics, ACE or ARBs, calcium channel blockers, is very, very important. And expect that you may need to use more than one drug. Note that you do not want to use both an ACE and an ARB together. That's not a good idea. And that beta blockers may be indicated for some subgroups of patients with heart disease, but are less preferred as first-line agents for people with type 2 diabetes. You can find detailed information on different possible drug choices. For example, on the screen here, there's a list of ACEs and ARBs, and you can click on these medications and find very relevant details with respect to the dosing and initiation side effects of the different classes of medicines. So moving on to other things besides blood pressure, lipids is very important. And there is extensive evidence that use of statins in people with type 2 diabetes improves important cardiovascular outcomes. And current guidelines in the U.S. Recommend aggressive use of statins. So if people have coronary heart disease as well as diabetes, or if they have an LDL cholesterol greater than 4.9 millimoles per liter, then high-dose statin used with atorvastatin or rosuvastatin. You can see the list of statins here. In the top two, atorvastatin and rosuvastatin, when used at the higher range doses, are considered high-intensity statins. And so if you have a patient with diabetes and heart disease, they should probably be on atorva or rosuva unless there's a really good reason for them not to be. For example, pronounced muscle side effects or myopathy, something like that. Other than that, these are very important components of the treatment of type 2 diabetes, especially in people with heart disease. But even in people without heart disease, most would qualify, almost all would qualify for a moderate dose statin. And looking at this very helpful list of agents, you can see what specific doses and agents fall into the category of moderate dose statin. So this is a really, really important part of the management of type 2 diabetes, and probably as in blood pressure and lipid control, both probably as important as glucose control for most patients. There's going to be some shuffling in the lipid guidelines. Joanne and I think that we're going to see some changes in the lipid guideline recommendation in the next couple of years because of recent studies that suggest benefits from PCSK9 inhibitors in some subgroups of very high-risk patients and the demonstrated effectiveness of those drugs in terms of important clinical outcomes. However, in the U.S., these agents cost approximately $14,000 per patient per year. and that's going to be an obstacle to their widespread use. In addition, even though they're approved for use now, the long-term safety of these agents is based on very scanty data. So my own personal philosophy is going to be to sit back for a while and see what happens. But I think that in terms of the safety of the newer agents, but in terms of clinical guidelines, it may be that we'll revert back to a lipid guideline with LDL goals in the near future, rather than one that just says if you have diabetes, you should be on a statin. And patients without diabetes, the treatment decisions are based on 10-year cardiovascular risk. We may see reversion in the next couple of years to lipid guidelines that are LDL-driven. So you have to sort of fasten your seatbelts and keep checking in on this website, as well as your radio and television reports. It seems like the media is on top of this as well. The next thing I want to talk about is the importance of lifestyle management. Lifestyle management in people with diabetes probably should be discussed first. It's really important. It has multiple components, including healthy eating, physical activity, weight management, and avoiding tobacco use, as well as moderate use of alcohol, appropriate use of alcohol. Lifestyle, a proper lifestyle. If a patient doesn't have really decent eating habits, it's going to be very hard to achieve glucose control no matter what medications we're using. And the benefits of physical activity are pronounced and have been quantified in a lifestyle guideline issued in the November 2013 circulation guidelines. It also included new risk engines, as well as lipid and blood pressure recommendations. So the lifestyle benefits are pronounced. Smoking cessation is #1 priority in patients that are smoking. Most patients that are smokers, and we all know about that. We're not going to devote detail to that, but there are different treatment options available to assist with smoking cessation, and you can get the details of those on the website. Antiplatelet therapy, including aspirin. In patients who can't take aspirin, sometimes clopidogrel is a benefit. And generally speaking, people with diabetes, men over 50, women over 60, or people with high cardiovascular risk, people that have established heart disease are strong candidates for antiplatelet therapy. Which brings us to glucose management. Glucose management is a cornerstone of diabetes treatment. If persons have present with a very high glucose levels over 16.6 millimoles per liter at the time of diagnosis, then the use of insulin is clearly indicated and should be used. Now, many of these patients, if they prove to have type 2 diabetes, may not need ongoing insulin treatment, but initially that would be very much indicated if the person has these very high glucose levels. Turning our attention to people who are who already recognize with diabetes and have the need for glucose control, the average patient, what is the treatment priority? The first treatment priority, clearly metformin. Metformin is a very well-established drug. It has great cardiovascular profile. It has favorable effects on lipids, and it's the cornerstone of treatment in patients that can take it. Patients who can't take it would include those with congestive heart failure that's uncontrolled, or people with impaired renal function. But metformin is a go-to drug. Its principal side effect, the most common side effect, is GI symptoms. And if the person can't take metformin because of GI problems or other problems, then we need to consider other medications. And other medications that could be considered in such a scenario are listed here. They include secretagogues, such as sulfonylureas, basal insulin, DPP-4 inhibitors, GLP-1 agonists, SGLT2 inhibitors, alpha-glucosidase inhibitors, and TZDs will treat as second-line agents today, and the other drugs probably have more favorable first-line potential. So those could all be considered either as alternative first-line agents, or in the event of a person who's started on metformin and needs another agent, as second-line agents. There's been particular interest recently in the class of SGLT2 inhibitors due to the publication recently, a couple of weeks ago, of a paper by Zinman and colleagues in New England Journal of Medicine that we include now on the website that showed that empagliflozin, one of the SGLT2 inhibitors, had like about a 35% reduction in mortality, which is sort of unprecedented in a glucose-lowering drug. Other than metformin, we don't have super strong evidence of mortality benefits for glucose-lowering drugs. So this is creating quite a stir. Now, so far it's just one study. My own personal philosophy is I like to see 2 studies before I change my practice, but you need to keep your eye on these SGLT2 inhibitors. They may move up the ladder in terms of preference, and they and metformin actually have the best cardiovascular profiles at the moment. So I think that if treatment goals are not achieved, you can go on to use 2 or 3 agents. Eventually, many people need insulin. And emerging alternative therapies include things like bariatric surgery, which causes a remission in type 2 diabetes in a high percentage of patients that take it. The likelihood of remissions higher in patients that are younger or earlier on in their diabetes course. There's also some ultra-long-acting insulins, the Glutec and others, and inhaled insulins that are discussed on the website, in which we won't go into detail on today. I don't view those as agents that are, we're still trying to figure out the appropriate use of these agents. I don't think any of them are going to be big game changers. So I'm going to turn it back over to Dr. Sproul-Hillen, and we'll be able to handle questions towards the end here. Thank you.
Okay, I just want to also point out that there are many guidelines that you can preview directly from the website here. And we have guidelines from Europe, international, North America. And you can see that there are the latest guidelines from the ACC-AHA website that Patrick discussed. Regarding the recommended statin use for people with type 2 diabetes, and also the latest JNC8 guideline is directly available through the website by just a link. I'm going to talk a little bit now about some of the follow-up recommendations that are for people with diabetes. Follow-up for diabetes, there isn't a strong evidence base to suggest any particular interval of follow-up, but I think it's considered a standard of practice for most patients with diabetes to be assessed at least every 3 to 4 months, and more frequently if people are having trouble achieving their care goals. The relapse rates for people with diabetes is very high, and by that I mean that if a person has an A1C that's at target, they have about a 30% risk of being not at target within a year. So the relapse rate is very high, which is one of the reasons why you want to continue to follow people very closely with diabetes and check A1Cs at least every 6 months, or maybe even earlier if you have concerns about relapse being an issue for them, a potential issue for them. If someone is in excellent control on very minimal therapy, you can stretch A1C testing and monitoring to yearly. Also, it's one of the reasons why we try to see patients back with diabetes fairly frequently is there are a number of things that need to be done to monitor for complications. Dilated eye exams are recommended every 1 to 2 years. Annual assessments of kidney function are recommended that include a serum creatinine test and a urinary albumin excretion test. Also foot exams, a comprehensive foot exam that includes vibration, sensation, or monofilament testing is recommended annually. And it's also a good idea to just examine the feet at every visit when you see patients. Just a visual assessment for any issues. And I often think it's a great idea to combine your feet assessment with some education about how to take care of your feet. Also, there are a number of patient instructions that are recommended that you review at your routine assessments for people with diabetes. It's important that patients understand that diabetes is a progressive disease, that even if they're doing everything right, they may need to move on to more advanced therapies. And it's important that we don't give patients the impression that that's a sign of failure just because they need to move on in their treatment. That can be a real barrier to to continuing to maintain good control in patients if they feel guilty or blame themselves for the progressive disease. Blood sugar, SMBG testing, blood sugar monitoring is a cornerstone of treatment. We recommend it for most patients with type 2 diabetes, but it's probably overdone a little bit in terms of many patients are testing more than they need to. In general, we like to say to test if you're going to use the results. So if a patient is going to learn something from testing with regard to how eating or physical activity or their medications are affecting their blood sugars, then that's fine. But just to do testing for the sake of testing is not really a cost-effective thing to do and has not been shown to improve outcomes in patients with type 2 diabetes. So with patients on oral agents and at goal and with minimal risk of hypoglycemia, SMBG testing 2 times a week may be appropriate. For patients that are ill or on insulin or changing therapies or on a pump, maybe testing 8 times a day would be necessary. So there are no real cookbook decisions around self-monitoring for blood glucose. I think you really need to take into consideration a number of factors and how that patient is using those blood sugars when you're recommending frequency of testing. Let's see. And it's also important when following up with patients to ask about hypoglycemia, if they're experiencing any symptoms of hypoglycemia, and to make medication changes that would address that if they are. Okay, I want to point out on the website that most of what we've talked about today and what's on the website is all referenced, and you can actually find full links to these references by clicking on the links within the website. And there are some really great studies that are here to review. This is the study by Getty, which showed that multifactorial intervention in patients with type 2 diabetes and microalbuminuria can decrease the risk of complications, microvascular and macrovascular, by about 50% if you just do a multifactorial intervention that focuses on the things that we've talked about today. I also want to show you that there are some online resources here that are very easy to link to. This article right here, The Management of Hypoglycemia and Type 2 Diabetes, will outline all of the drug therapies that we talked about today and the studies that show their efficacy, and it's kind of a useful little resource. You can see it outlines the biguanide, sulfonylureas, meglitinides, and gives you their advantages and their disadvantages. Another very nice piece of information that you can find here are some patient leaflets. And this covers information all the way from what is diabetes, very nice information for somebody who is newly diagnosed, to just kind of general things that you can do to stay healthy. This includes, healthy eating, exercise, taking your medications, monitoring, and all of that. What treatments work, and a nice pamphlet here on should I take insulin. This can help you if you have patients who are really resistant to the idea of taking insulin. And then lastly, I want to point out here that there's some related BMJ content here that can be very helpful, and especially these key modules. So they're initiating insulin in type 2 diabetes, using insulin degludec for type 2 diabetes, insulin pump therapy, and an introduction to diabetes. And these are modules that you can listen to and get credit for that are quite good. So I'm going to let Patrick do a little closing statement here, and then we'll turn it over to Sheila for more questions. But thank you very much for giving us the opportunity to talk to you today.
Okay, and by way of conclusion, I would just want to say this, that if you look at where we are with diabetes care in most nations today, we're in much better shape in terms of management of glucose, blood pressure, lipids, and managing cardiovascular risk than we were 15 years ago. We have more medications in almost all these drug classes. We've had major reductions in the heart attack, stroke, and death rates in people with diabetes across many different nations in the last 15 years. So those of you that have been seeing patients for the last 15 years ago should feel pretty good. This should be a feel-good moment for you, that all that hard work is paying off for thousands and thousands, hundreds of thousands, and actually millions of patients. On the other hand, we have trouble with increasing prevalence of diabetes, and maybe we can discuss some of the challenges of that in the question and answer period. But I think that the twin messages are this. One, we're doing a great job. Two, we could always do better. And three, that the care needs to be personalized to each patient that we see. So with those thoughts in mind, let's wind up the planned part of this presentation and open it up for questions.
Okay, thank you very much. We've had 3 or 4 questions, and we're going to be posting them to the group. So why don't we start with the first question, and then I'll post the rest. First question was, what would be the scheme of choice for the use of insulin therapy in patients with type 2 diabetes? And we have, I think, some details of that in our treatment detail. So if Patrick or Joanne, you want to just take that away while I enter the second question.
Sheila, can you repeat the question, please?
Yes. What would be the scheme of choice for the use of insulin therapy in patients with type 2 diabetes?
Well, I think that's a tough question because it really depends on the scenario that the patient is presenting with. If the patient is on oral agents and is not too far away from achieving their care goals, starting with a basal insulin probably is the right way to go. But if they're very far from care goals, I'm talking about A1C goals, then starting a multi-dose insulin regimen would probably be of a better route, since that's where they're going to end up needing to go anyway. And in that case, you would often discontinue some of the other agents, oral agents, especially those that might contribute to hypoglycemia at the same time.
Okay, what if we have some details in the treatment details section. So, you know, we can just show participants how we can click on some links and we do have the option of the very common regimens of either adding basal insulin to oral agent, metformin, or switching to basal bolus insulin.
I believe also, Sheila, in the resources, there's a really nice handout for how to start insulin. I'm trying to remember where. I believe it was in the online resources. No?
Yeah, I would just say that with respect to insulin, that type 2 diabetes is a disease of insulin resistance. And while insulin does help in terms of controlling hyperglycemia, the other treatments that are becoming available have mechanisms of action that more directly address the insulin resistance components of the disease. That's something to also keep in mind.
Okay. The second question is, can type 2 diabetes be prevented?
So we know from the diabetes prevention program trials that diabetes is preventable in approximately 50% of the case, or you can reduce it by about 50% using lifestyle interventions lifestyle is probably the preferable way to go, but is often a difficult thing for patients to achieve intensive lifestyle changes. Metformin also is a great choice and has been shown to prevent diabetes in people with a prediabetes condition. Our inclination is to use both metformin and lifestyle in situations of prediabetes if they're, depending on what the patient treatment preferences are, but definitely patient preference for lifestyle or drug therapy would play into your decision.
Okay, we have another question. How long do we wait for glycemic control with lifestyle changes before starting with medical treatment?
Well, I think, given the evidence that metformin is beneficial even in people with prediabetes, I would have a very low threshold for initiating metformin very early on in conjunction with lifestyle changes. Many patients, though, do not like the idea of using medications. And so I think that, for most patients, you can wait until their A1C is getting close to the 7% threshold before initiating metformin if you have a patient who's resistant to the idea of medications, but otherwise I would start metformin very early on.
In addition to that, once the person is diagnosed with diabetes, the equations change a little bit in terms of the importance of lipid and blood pressure control. So if a person, I agree with Joanne, you should use metformin right out of the box with somebody that's diagnosed with diabetes, and actually in many patients with prediabetes as well. But if the patient's really resistant to that idea, there may be ways you can benefit the patient by looking closely at their blood pressure and lipid management and addressing smoking and as well as lifestyle weight management issues.
Okay, the next question is there evidence to suggest that exercise helps stimulate formation of new glucose receptors?
Exercise is of unquestioned benefit for most patients with diabetes. The only exception would be somebody with unstable angina or something like that, where you have to be careful about exercise. But for the vast majority of patients, exercise is beneficial. I'm not sure of the answer, directly the answer to the question of the effect of exercise on various types of receptors, but exercise does have benefits that are very, very broad. They help you with your weight, helps you with your glucose, improves HDL, and reduces blood pressure. So that the benefits are quite broad and quite universal, and of course are not limited to people just with diabetes or prediabetes either. Probably 30 minutes of exercise a day would be a universal prescription for better health and would substantially, in the long run, reduce healthcare expenditures in many, many countries. Now, if you want more detailed information on the precise impacts of exercise on these various parameters like weight, blood pressure, etc., there's a guideline issued by the American College of Cardiology, the American Heart Association, that was published in Circulation November 2013 that includes a position statement on lifestyle management, and in the appendix of that document gives precise review of the literature with precise estimates of the effect of physical activity changes on lipids, blood pressure, and weight and glucose.
Okay, next question. If on first presentation, patient is found to have, for instance, A1C greater than 12%, and never attempted lifestyle modification on any oral hypoglycemic, what is the recommendation? Should we put him on insulin on this visit?
That patient will do better if you put him on insulin. When the A1C is that high, putting somebody on insulin can give their pancreas a little bit of rest, allow some of its insulin-producing capacity to return. You, at the same time, would want to emphasize lifestyle changes and maybe even use oral agents. When we put patients on insulin at diagnosis when they're in very poor control, I would say A1Cs of 11% or above would be a reasonable threshold for just initiating insulin. It doesn't have to be a permanent thing, and we can tell patients that you know, with lifestyle changes, dietary changes, those kinds of things, it may be that you can get off of insulin, but the best thing to start with is to give that pancreas a rest and let it renew its insulin secreting capability.
Okay. Next question. This is about an emerging therapy. Can you talk a little bit about bariatric surgery? When would this be recommended? Who would you recommend it for?
Yeah, that's a very good question. For people that have type 2 diabetes, let's just talk about people that have type 2 diabetes with respect to bariatric surgery. There have been a number of studies published lately, some of which I was involved in, where we've looked at large cohorts of patients who have type 2 diabetes who did and then, you know, as opposed to did not have bariatric surgery. And it's pretty clear that if you have bariatric surgery early on in the course of your diabetes, before you're on multiple hypoglycemic agents, before you're on insulin, that about 70 to 80% of those patients will have remission of their diabetes. They will become euglycemic on no glucose-lowering medications. They'll have remission of their diabetes. And that remission, however, may not be permanent. Like we found that after 7 years after the bariatric surgery, more than half of the people that reverted to the non-diabetic state following surgery slid back into diabetes. So for many patients, it's not a permanent thing. It's not a permanent remission. So from the management point of view, you can't just write those patients off. You need to stay on top of them. Whether that loss of the remission of diabetes, whether the recurrence of diabetes is related to weight gain, yes, to some degree it is. It's also related to aging. That's still being worked out. But bariatric surgery can be beneficial. The average age at which the bariatric surgery was done in this cohort of, you know, maybe 6,000 or 7,000 people that had it was 40 or 42 years old, and 80% of the subjects who had the surgery were female, and many of them had benefit. Now, having said that, no one really knows how, you know, there's bypass and banding. Banding just closes down the capacity of the stomach and is not really a long-term solution to diabetes. The bypass is more beneficial in general. But no one really understands metabolically the molecular mechanisms by which the bypass leads to the remission of the diabetes. And there's a great deal of research going on in that area right now, and it may be that in the next few years we may be able to have access to pharmacological agents that have some of the same effects that bariatric surgery has now. So I wouldn't send all my patients out for bariatric surgery. There's substantial complication rates that are of the order of 20 to 30%. The fatality rate, which used to be 1 in 200, is much less now. It's probably 1 in 500 or 600. But the complication rates can be high. Both early and late complications. So it's certainly not a panacea, but it can be helpful for some patients. But I would say wait for a few years and see if we can develop pharmacologic agents, identify pharmacologic agents that convey some of the metabolic benefits that can be achieved by bypass surgery.
Patrick, let's just click on the emerging therapy section for just 1 second here. There are always going to be emerging treatments, and this is a good section where, you know, our readers can take a look at what the latest evidence is. And here we describe some of the issues in bariatric surgery that you've just gone through. Next question. What do you think will happen to lipid management recommendations over the next few years?
That's a tough question because who knows what will happen in the next few years. However, there are recent developments that really suggest that changes are on the way, and I addressed a few of those earlier. Right now, the guidelines for lipid management in the U.S. are based on a person's level of cardiovascular risk as long as the LDL level is not over 90 milligrams per deciliter, which is a pretty high level. So the emergence, though, of clinical trials related to new classes of lipid-lowering drugs that reduce cardiac events in some high-risk patients suggests that there's going to be changes in the near future and that we may revert to an LDL-based guideline. The cost of the new medications is so high that $14,000 a year for the PCSK9 inhibitors, that their widespread use is going to be problematic from the resource point of view in most national healthcare systems, including in the U.S. But it may be that some subsets of patients, such as those that are seriously intolerant of statins or those that have advanced cardiovascular disease and cannot achieve LDL levels that are very, very low with statins, might be candidates for this new treatment. So, you know, I think that changes are on the way. My prognostication would be that we'll revert to an LDL-based guideline, and that the guideline will have to take into account more fully the use of combination lipid therapy in addition to just a basic first-line treatment with the statins. Joanne, what do you think about that?
I think that's true. It probably will revert back to an LDL goal at some point in the future, but we also have to be cautious that there's a number of studies of combination therapy. For example, AIM-HIGH study trying to show that niacin on top of statins had a greater effect, and it didn't. In a CORD study, we tried to show that fenofibrate would have on top of statin therapy, would have a better or more beneficial effect, and it didn't. So I think we need to be careful about the combination therapy and thinking that we can do better than statin therapy along with some of these things.
Okay, next question. What will be the treatment plan for the newly diagnosed type 2 diabetes and is in the honeymoon period of diabetes?
You know, I think when I hear that honeymoon period of diabetes, I think more about type 1 diabetes. And in patients with type 1 diabetes who are first diagnosed, they can go through what we call a honeymoon period where their control is relatively easy, or it looks like they don't have diabetes for a little while after they are first diagnosed and treated. For type 2 diabetes, I don't really use the terminology honeymoon period. I feel like if you've been diagnosed with type 2 diabetes, you always have it. It may be in remission or clinically undetectable with blood glucose testing if somebody loses weight, but if you gain the weight back, it's going to come back. So I don't really use the thought of the honeymoon period for people with type 2 diabetes. It is a progressive disease that can wax and wane based on how well somebody is doing with their lifestyle.
Mm-hmm. Yeah, and guidelines pretty much.
I agree. I think you need to get people on treatment, presumably metformin if they'll tolerate it, as rapidly as possible, and get them to the educator, make sure that they understand the basics of lifestyle management and get some positive support for that. And then consider the implications of the treatment. The only reason we recommend early and aggressive treatment is because we have a drug, metformin, that's widely considered to be safe, has a positive cardiovascular benefit, and a pretty good safety profile. So when we talk about early and aggressive treatment in type 2s, we're talking about metformin. The SGLT2s look promising, but they're expensive. Some of the other classes of medications aren't quite so beneficial, including sulfonylureas. There's some skepticism about the role of sulfonylureas with respect to their cardiovascular impacts and their weight gain and their potential for hypo. So you need to weigh these things, but I think that early aggressive treatment with drugs that are safe and have low risk of hypoglycemia is definitely the top of the list when you're looking at your patient with newly diagnosed type 2 diabetes.
Yeah, we've come around to this a couple of times, and this is certainly in line with guidelines to start lifestyle changes and metformin at the outset for most people. We have another question about aspirin use, so maybe we can go back to the treatment details and just click on our aspirin subsection at the top and discuss who gets aspirin when.
So, it used to be that we recommended aspirin for everybody with type 2 diabetes, but that is no longer recommended because there are risks associated with aspirin use. So it becomes a decision about whether the benefits of aspirin use will outweigh the risks, which are mostly related to GI bleeding. So there are several different guidelines out there that recommend different ways of assessing whether for primary prevention aspirin is warranted. The American Diabetes Association's current recommendations are that generally men greater than 50 years of age or women greater than 60 years of age with one additional risk factor, cardiovascular risk factor, should have an aspirin recommendation. And it's not recommended for primary prevention in individuals younger than that. I should mention that there are some draft guidelines out there from the U.S. Preventive Service Task Force that will, if they are put into practice, will change our recommendations and also factor in the benefits of colon cancer prevention that patients receive from aspirin use. So for secondary prevention in people with pre-existing coronary artery disease, it's a no-brainer. They should be on aspirin or an antiplatelet agent unless there's some big reason why they can't be. But for primary prevention, it's a little bit more of a gray area, and I think the easiest recommendations are those of men greater than 50 years of age or women greater than 60 years of age with one additional risk factor, or using the U.S. Preventive Service Task Force table, which they have a table in there that looks at the age of the patient and their cardiovascular risk, and you can get a recommendation that way as well.
Okay. We have another question. If patient is well controlled on oral hypoglycemic but wants to start insulin, shall we change to insulin?
I don't know why you would want to change therapy in somebody who's doing well on their agents unless they're having side effects or concerns related to the oral medications. But insulin is never really a bad choice for patients, and the disease is progressive enough that eventually many patients will end up on insulin anyway. And there are a lot of people out there who advocate for starting people on insulin at diagnosis, even if their A1Cs are lower, just so they become familiar with insulin and aren't afraid of it later when they really need it. So I wouldn't say that you shouldn't use insulin in that situation if that's a strong patient preference, but I might try to talk the patient out of it if they're doing well on their oral agents and there aren't reasons for a change.
And if you're going to use it, just use basal. Start with basal, not basal bolus.
Yeah, maybe we could just scroll down just a bit where we, again, just to show the various options. A little further up, we have the option for basal insulin added. A little further up. Basal insulin added to continued metformin.
Oh. Okay.
So, if we're on goal, on metformin, this would usually be the first option, and we have some details here.
Yep, starting basal insulin at 0.1 units per kilo is a common way, or even just starting, with around 10 to 20 units of long-acting insulin in addition to the metformin, and then.
Yeah, which relates to I think we have time for one final question. When to stop oral hypoglycemic drugs after insulin initiation. So maybe that'll be our final question.
I think that partly that depends on whether the oral medications are contributing to hypoglycemia risk. So very frequently when people start insulin, we would either reduce the dose of a sulfonylurea or stop it. I don't really see a lot of advantages to using sulfonylureas and insulin together, so I would typically think that would be a good time to stop the sulfonylurea. Also, cost can be a factor. So if costs are a factor for a patient, managing without the oral agents and insulin alone can be a consideration. Though typically I think it's a good idea to continue at least the metformin in addition to the oral agent, and in addition to the insulin for people with type 2 diabetes, unless there's a reason why metformin shouldn't be continued.
Okay, I think that we are about finished with the question session. So if we could ask all participants to please fill in the survey and download your certificate. It would be very helpful to us to have the answers to the survey questions. And I would again like to thank our speakers for a wonderful presentation and for everybody for coming and listening. Thank you very much.